So we are today going to speak about mainly about acute coronary syndromes. There's nothing new actually. Everything is things which you already know. So we have to just refresh our knowledge, because acute coronary syndromes, is very common these days. It's actually commoner than we can say about 10 years ago. It's not so common, but they are becoming increasingly common. So I think it's important for all the doctors to know how to manage if they get acute coronary syndrome. So we'll first discuss about typical and atypical presentations, and then we'll proceed to refresh our knowledge about how to manage acute coronary syndrome. So to start with, we'll start with the case scenario. This is real case scenario. There was a 47-year-old man came to the OPD with epigastric burning chest pain for about 2 hours, which was partly relieved by taking some warm water and burping. So this is, he says he had gastritis before. So when he had gastritis, he used to take some warm water and burp several times. And if that does not relieve the symptoms, he used to use some over-the-counter antacid pills. So he tried all that, and still the pain was like, he says it was like his gastritis, which he has experienced before. But the thing is, all the maneuvers he did, all the tablets he took, it was not getting better. So he was finding it increasingly difficult to either sit or lie down. So he came to the OPD, and he explained that he had some alcohol last night with his friends, and he also had some spicy food. So he was attributing everything to a bit worse or bit serious episode of gastritis. So he wanted some medications, and actually he was requesting some IV medications because he was requesting for injection to get better. So doctors in the OPD referred him to the ETU, and they did the ECG. So this is the ECG. You can see it clearly shows ST elevation leads 2, 3 and AVF. So what I wanted to highlight here is, now then he came to the cath lab. So we did a coronary angiogram. You can see the right coronary artery is blocked from the beginning. And then we open up the blocked artery, put a wire and balloon, now put a stent. So it did a primary PCI. And actually, if you see closely, you can see that his left coronary artery also filling retrogradely from collateral. So that means he has severe triple vessel disease. So actual presentation was with the inferior STEMI, but he has severe triple vessel disease. I have not included the left coronary angiogram here, but he needs a bypass for the revascularization for the other territories. So we have fixed the right coronary artery, but for other arteries, in cardiac PCI is not possible. He needs a bypass in the future. So what I wanted to highlight here is, now is usual what we have learned as medical students, as doctors, what we describe as ischemic or cardiac sounding chest pain. This is a term we use very commonly in the ETU and all the medical wards. It's described as central retrosternal crushing, constricting or pressing pain, which is usually very severe, which can be radiated to the left arm, jaw, or even your teeth. Sometimes it can be even radiated to right arm also, and sometimes it may be radiated to between the shoulder blades into the back. So usually it can be associated with autonomic symptoms like sweating or nausea, vomiting, and if the pain is severe and it occurs at rest and persisting, we call it likely the pain of acute coronary syndrome, like unstable angina, non-ST elevation MI, or acute ST elevation MI. So if the patient has this kind of pain occurring with exertion and which is relieved by rest, or sometimes which can be precipitated by cold weather or emotion, we call it chronic coronary syndrome, or we used to call it stable angina in the past. Now we call it chronic coronary syndrome. So that is what we have usually learned, what is the cardiac chest pain. Now because we have very large amount of very high incidence of acute coronary events, now atypical presentations are also, they are still a minority, but they are now a significant minority, because large absolute numbers, there are significant amount of patients who get atypical presentations. So it's important because these atypical presentations are common in patients who are relatively younger. So now the demography of the ischemic heart disease is also changing. Now younger patients are getting MIs, females are getting MIs, and CKD patients are also prone to get MIs, and we have very high incidence of young diabetics, 20 years, 30 years diabetics. Especially in this area, Anuradhapura Rajarat area, we have lots of young diabetics. So now diabetes is so common, people don't consider it like to be an illness, like everyone has diabetes, right? So it's becoming normalized, people to have diabetes. So lots of young diabetes. So that's why younger patients are getting diabetes. So earlier, when we had about patients around 30s, 40s females, we thought, we know that females are they have some protection against ischemic heart disease, so they don't get until menopause. So that was the usual case scenario about 10-15 years ago. Now it's not so. So there are people, young females, 30s, 40s, getting ischemic heart disease, acute coronary syndromes. This is a 32-year-old housewife, no previous risk factors, present with chest pain for again 2 hours. So it was anterior STEMI. You can see the left coronary artery, left anterior descending artery is blocked here, right? So we proceeded to open it up. Balloon, and then after opening up, you can see now the flow has been restored in the left anterior descending artery. So 32-year-old female. So if this happens in a Western country, they would not think of a MI, because 30s, 40s females, they don't consider. MI is very low down their list. So what are the atypical presentations? So they can present with indigestion. They may say it's gastritis. They may say it's burning, right? They may also will say it's usually relieved by burping or taking a sip of water, right? And especially the elderly patients and diabetic patients, they just will come and say they are feeling not well. They can't exactly express what they are feeling. They will say not well. Unavage, angata maru. So they will have various symptoms which they are also unable to express. But if a diabetic patient, CKD patient, or elderly patient comes with any of these symptoms, you have to consider possibility of a acute coronary event. And they may also say they have epigastric fullness. And some people who have angina, they complain of postprandial angina. They say when they take a heavy meal, they feel burning of the epigastric region. So people, sometimes doctors attribute this to gastritis or gastroesophageal reflux. So we have to be very careful because our patients are getting coronary events at younger age. So we have to have a high degree of suspicion because we are South Asians. Genetically, we have a very high risk of acute coronary syndromes and ischemic heart disease. So I think when we consider the acute coronary events, better to take more caution and over-investigate rather than be sorry later. So inquire into the risk factors, whether they have diabetes, hypertension, smoking, traditional risk factors, and ask about the family history always, whether there was a young MIs in the family and whether there were sudden deaths in the family at a young age. And do not assume it will be gastritis. So ECG will most likely show at least subtle changes. Most of the ECGs, about 95%, will show some changes. So what you can easily miss is inferior ST elevations is easy to miss. So remember to look at the inferior leads because you might not see the typical ST elevations. It will be very tiny Q wave followed by no or very mild ST elevation and there will be a T inversion. So T inversion in the inferior leads is the thing to look for. Absence of R wave and presence of T inversions in the lead 2-3 AVF you have to look for, because we see that is the one. I mean, anterior STEMIs, most of the doctors, even house officers, they can detect. So inferior STEMIs are easy to miss. So you have to look at the inferior leads more closely if you're suspecting MI. And other thing you can miss is hyperacute T waves, because patient present very early, they have hyperacute T waves. So you don't know. I mean, even we find it difficult to say whether it's hyperacute T waves or a normal T wave. So what you should do is you have to repeat the ECG and take the clinical picture into account. So in a small and a significant minority, ECGs can be normal. So remember the ECG, even if the ECG is normal, you can't rule out acute coronary events. So in these instances, I mean, if your gut feeling is acute coronary syndrome, but you do the ECG is normal. So then that is the time where you have to use the high sensitive troponins. Now when we are talking about high sensitive troponins, it's available in this hospital free of charge. It's a very important investigation. It's not available in the private sector in Anuradhapura. Even our normal troponin is very sensitive. So high sensitive troponin or any sensitive troponins are not available in the private sector. So our hospital troponin is the best. So if I want to get a patient to get a high sensitive troponin, patient should come to the hospital in Anuradhapura. So because I mean, private sector will do high sensitive troponins, but they will send it to Colombo. So it's no point getting high sensitive troponin positive report next day. You have to get it within 1 or 2 hours. The thing is, now because high sensitive troponin is available, people tend to misuse it. So all the patients, you should not do high sensitive troponins. I mean, these are not in the guidelines, because high sensitive troponin is guidelines will say all the chest pains do high sensitive troponins, right? But in our scenario, we have to think about resource utilization also. So you can first do a normal troponin. If that is also negative, then you can do a high sensitive troponin. So if the ECG is normal, you think it's MI, do a normal troponin. It's normal. Then you can do high sensitive troponin, right? Other thing is you have to remember troponin can be positive in other instances also. For example, if a patient with non-heart failure comes, if you do a high sensitive troponin, it will be positive. If a patient with tachycardia for some reason, atrial fibrillation or any kind of SVT comes, if you do a troponin, it will be positive. And the CKD patients comes, if you do a high sensitive troponin, it will be positive. So you have to keep in mind, high sensitive troponin is a very useful tool. At the same time, if you do high sensitive troponin on unnecessary patients also, then you will fall into trouble. Then you can't disregard when it becomes positive. Then you have to ask for the cardiology opinion. So that's a problem for us also. So typical ECG changes. So we will move to typical ECG changes in the STEMI. Everyone knows ST elevation in 2 or more contiguous leads. So it has to be contiguous leads. Like it should be in the same territory. So it can be anterior, can be septal, can be anterolateral, inferior, inferior-posterior, and true posterior. True posterior STEMI is important to know. I mean, most of the doctors know this, but for the house officers, true posterior MIs, you don't see ST elevations, but there will be ST depressions in the leads V1 to V3 with the upright T wave and upright R wave. So that means, you see, posterior STEMI. I mean, we can't call it a STEMI because there are no ST, so we call it posterior MI, true posterior MI. And there is a lateral STEMI, and ECG can be apparently normal even if the coronary artery is 100% occluded. I mean, angiographically it's a STEMI, but ECG can be rarely normal, especially if the occluded artery is a circumflex artery. You may see normal ECGs. Circumflex 100% occluded, normal ECG can be there. Right, so this is this left image shows the progression of a STEMI. Normal ECG is like that. Then there is a peak T wave, and there's degrees of ST segment elevation. So ST segment elevation go up and go up and go up. So you can't see the T wave separately, and then you get Q wave formation, and then later T wave inversion. So now it says you have to have 0.5 millimeters and 1 millimeters, that kind of cutoffs have been given by all the guidelines. But the thing you have to remember is the amount of ST elevation it can vary from patient to patient. One reason is the height of these ST elevations and height of the ECG complexes will depend on the conductivity of the patient's tissues. Now, if you get a very obese patient, you will get small complexes. So, and because the complexes are small, ST elevations will also be small. It's the same thing like if you have fat, if you have fluid, if you have any thickened pericardium for any reason, then you might get complexes which are small. So ST elevations will also be less height. At the same time, if you get a thin patients, those patients can have ST segment elevations which are very high, and depending on the occlusion, the site of occlusion in the artery also, you can get different heights of ST elevations. For example, if you get distal right coronary artery occlusion, you will get a very high ST elevations. If you get a proximal right coronary artery occlusion, ST elevations will be minimal. And another useful tool is when you are suspecting acute MI, even before you get ECG changes, within few minutes, like 5-10 minutes, you can have changes in the echocardiogram if it is available. Don't send all the patients with chest pain to do urgent echo to rule out MIs, but that is also can be used, right? So then we come to the non-ST elevation MIs. Patient will have usually horizontal or down-sloping ST depressions, and some people can have deep symmetrical T-wave invasions. So don't take all the small T inversions as MIs. So we have seen patients getting admitted to the hospitals for some other reason, like any other reason. Like females, they commonly get vertigo, dizziness, or some kind of pain under the breast. So they come and someone do a ECG and there are minor T inversions. So people diagnose unstable angina. Then we are in trouble because now, even if the patient had, even if we doubt the diagnosis of unstable angina, now we can't undo it. Now, when the patient comes to us, we can't say if it's not unstable angina because the clinician who saw the patient first knows best. So we can't say it's not unstable angina now. So patient will have to take unnecessary antiplatelet therapy. Especially, I think if there are any surgeons here, they don't like clopidogrel. So, but we have to give clopidogrel because someone has diagnosed unstable angina. So the overdiagnosis of unstable angina or acute coronary syndrome is also an issue. So then they will have to take lifelong medication. So if it's a minor T inversions, better not to diagnose as acute coronary syndrome. Maybe you can give some aspirin and statin, but don't give a diagnosis of acute coronary syndrome. You can say investigate for angina, then you can proceed on other investigations like stress test or a coronary angiogram, and then we can say we will be able to stop some of these medications. So if you give a diagnosis as unstable angina, then someone can ask us why did you stop the medication? Now patients can get another MI later. So then there will be a question will be asked, why did you stop the antiplatelets? So that is the issue, right? So to avoid unnecessary antiplatelets, should not diagnose small minor T inversions as unstable angina. So another thing we commonly see, patients are diagnosed as AVR STEMI. I mean, there's nothing called AVR STEMI. There is a thing called AVR ST elevation with widespread ST depressions in other leads. That indicates severe left main coronary artery disease or severe triple vessel disease, right? Left main or left main equivalent. So there is no place for, I have seen some patients being thrombolized for AVR ST elevations. I looked at the literature, but I couldn't find any indication to thrombolize these patients. They should have urgent coronary angiogram. Not urgent, should have a coronary angiogram, and they should have revascularization. So if a patient comes to AVR ST elevation, one thing we see is, one of the common things you can do is, other than usual antiplatelet therapies and heparin or enoxaparin, you have to control their heart rate. So if you have to give a beta blocker. So if you give a beta blocker, most of these patients, their ST elevations will, the AVR ST elevation will come down, widespread ST depressions will resolve. So they need anti-anginal treatment, especially a beta blocker. So these patients are very severely ischemic. Their myocardium is ischemic. So beta blockers are the ones which will help them. They are usually tachycardic. AVR ST elevations, widespread ST depression, they are usually tachycardic. So give a beta blocker. Sometimes patients can have unexplained bradycardia, ventricular ectopics, and ventricular tachycardia. Non-ST elevation MI can present with just with ventricular tachycardia and ventricular fibrillation sometimes. So this is one of the patients who came with AVR ST elevation and widespread ST depressions. You can see left main, there is a 99% stenosis in the distal left main, and this is the distal left main. Severe disease. LAD also 100% occluded here. Diagonal arteries, there are severe disease. RCA 100% occluded here. So actually, he's only surviving in this circumflex branch. So he underwent early CABG. So this is a typical presentation if you do angiogram on these patients. So that's why sometimes when you ask for some ET or medical ward asks, there are patients with AVR ST elevation and widespread ST depression. Would you do urgent intervention? So we are not very keen to do very urgent intervention because we can do angiogram, it will show this. Then we can't usually we can't do any interventions on this. They have to undergo CABG. So CABG will not be done as soon as we like. So that is why we are not that keen to go and do angiogram on a patient with AVR ST elevation and ST depressions. In the ideal setting, they should have very urgent angiogram and urgent bypass grafting. So sometimes, rarely, there are patients who we can do something, but most of the patients with that kind of presentation will need definitely CABG. Looking at few atypical presentations, typical ECGs, something called valence, biphasic T waves in lead V1 to V3. And this is valence A and valence B, deep symmetrical T inversions in V1 to V3 and go up to V4, V5 also. So that will indicate severe lesion in the LAD, left anterior descending artery. So these are the patients who will need early angiogram and fixing of the LAD. Otherwise, there is a risk they will get a STEMI, anterior STEMI in the near future. So we don't like these patients. We have to do early coronary angiogram.
Thank you so much.
And there is called De Winter syndrome. There is a ST depression, upstroping, and tall T wave. J point is depressed, and there is a tall T wave. This is usual ST depressions you will see in non-ST elevation MIs. This is a hyperactive T wave, and again, there is another problem is when patients with left bundle branch block or non-left bundle branch block or paced rhythm, and they come with chest pain. Then you have to, ECG is not usually diagnostic, so you have to go for the Garbosa criteria. I also can't remember Garbosa criteria, but you can look up. It's available in the, everyone uses smart devices nowadays, so you look at this Garbosa criteria and then you can diagnose MIs in those patients, right? This is called shark's fin ST elevation. Because ST elevation is so high, you can't distinguish R wave and T wave and ST elevation, everything is fused together. Right. This is one of the patients we had who presented with valence syndrome. There are heavy, LAD is not totally occluded, but there is severe stenosis with heavy clot burden. So we proceeded to do a clot aspiration in this patient. And then did the stenting. So flow has been established. These are the clots which we aspirated from the coronary artery. Flow is restored. So valence syndrome, when you see, we have to do early coronary angiogram. There is no doubt. Other thing is there are mimics of valence syndrome also. Sometimes patients with LVH can have deep symmetrical looking T wave inversions, and sometimes types of cardiomyopathies, like there's this thing called apical hypertrophic cardiomyopathy. So apical hypertrophic cardiomyopathy patients can have exact ECG findings like a Whelan syndrome. So, but usually if the patient has chest pain, significant chest pain, and Whelan syndrome, we do an angiogram. So if you suspect acute MI, acute coronary syndrome, do not wait for troponins if the ECG is diagnostic. So because time is important, right? So although the guidelines say do troponins, you wait for troponins only to rule out when ECG is normal or equivocal. You have to do serial ECGs and serial troponins, and you have to do high sensitive troponin if troponin is normal. That is the one that is not in the guidelines, but I think that is the way we should do things around here. So one issue is sometimes when the patient has first ECG normal, next ECG is usually taken on the next day. So the first ECG looks absolutely normal, and the next day ECG shows Q waves and T inversions. So the MI has happened during the hospital stay. So they are usually labeled as late presented MIs, but they are not actually late presented MIs. They are late diagnosed MIs. So I know that the doctors have heavy workloads in the hospital, but if a patient has significant chest pain, and especially if the patient is diabetic, please do serial ECGs. You have to, and another thing is sometimes ECG is done and it's in the BHT. Nobody has looked at the ECG. So you have to have a role in your wards. If a ECG is done, it has to be immediately seen by the doctor. Otherwise, nurses can't put it in the BHT. So there is no point taking ECG and if nobody's going to look at it. All right. So a little bit about how patients you should proceed with if in a case of STEMI, how you should proceed with STEMI or non-STEMI. In a case of STEMI, how you proceed with either PCI or thrombolytic strategy. So patient gets chest pain, gives a call to emergency medical services or ambulance, or patient can directly present to the hospital. The hospital can be non-PCI center or a PCI center. If you have to make the STEMI diagnosis within 10 minutes of first medical contact. So you have to take the ECG and interpret it within 10 minutes. So if the patient comes to the ETU, you have to take the ECG and decide whether it's a STEMI or not within 10 minutes. And sometimes you may have to do serial ECGs. So if you have a doubt, don't wait to ask for senior opinion. If you are not sure, you have to ask your seniors or even call the consultant, anybody, get the diagnosis. And then if you can't send the patient for PCI, like within 120 minutes, right? So you expect patient's infarct related artery can be opened within 120 minutes, right? Not that you can send the patient to the cath lab, not that you can send the patient to the PCI center. Patient has to be on the table and the artery has to be opened within 120 minutes, right? If you think that is possible, you call the primary PCI center or you call the cath lab and send for primary PCI. So primary PCI has to be done within 90 minutes of the first medical contact. Not from the presentation of that primary PCI center, from the initial first medical contact, from here. Right, so if you imagine time to PCI would be more than 120 minutes, you proceed with fibrinolysis. And fibrinolysis has to be delivered within another 10 minutes or at least 20 minutes. So within half an hour of the first medical contact. Reperfusion, like now we don't use streptokinase anymore. We use tenecteplase. I don't know how long we'll be able to use tenecteplase, but we might have to go back to streptokinase. But for the time being, we use tenecteplase. It's given as a bolus, right? So 10 minutes to do the ECG and interpret the ECG, and 10 minutes to give the reperfusion therapy. Right. So only important things to remember is sometimes ECG will take time, especially if it's in the medical wards. ETU usually they can do the ECGs, because the ECG technicians they have to go around the hospital taking various ECGs like pre-op ECGs, ICU ECGs. Now you can't just write the ECG form and expect them to do it quickly. if you suspect a STEMI, you have to get the ECG done, because doctor is the team leader. So you can't say it's the job of the cardiac physiologist or the ECG technician to come and do it when I write the form, especially for the house officers. So you are the leader of the team, so you have to get the work done. If the ECG technician is not coming, now managing emergencies, you have to, for emergency managements, everyone has to know how to do certain things. If the ECG technician is not doing, you ask the nurses to do the ECG. If the nurses are not doing, you have to do it yourself. Emergency management is like that. Non-emergency ones, you can write a letter to the director and say the ECG is not being done. Those things can be done. But emergencies, it's your duty to get the ECG done in time. Right? You can't say ECG technician didn't come. That is not an excuse. Right. So that is about minimizing delays. So you usually load the patient with, do the ECG, load with aspirin and clopidogrel, and proceed with thrombolysis within 30 minutes if non-PCI capable, proceed with primary PCI within 90 minutes if PCI capable, right? Right. So few things about patients who undergo treatment for acute STEMI thrombolysis. One thing is elderly patients. If the patient is older than 75 years, they say to give half the dose of tenecteplase, because they are very high risk to get ICH. And if the patient is more than 75-80 years old, don't give loading dose of clopidogrel. Give only 75 milligrams of clopidogrel, because again there is high risk of ICH in these patients. So remember, elderly patients need to be given less amount of medication. And we see this doesn't happen in our hospital, but patients who are transferred from peripheral hospitals, one issue is they put a catheter. I don't know how this came about, but don't put catheters to patients present with acute coronary syndrome. There is no need. I think this came from the time patients were not allowed to move at all after the MI, because there were no effective therapy treatments. So because they were going to stay in the bed, they used to put a catheter. I think that was the initial rationale. But please don't put catheters. It complicates matters. You put a catheter, there is hematuria. Now you will have to stop giving enoxaparin, aspirin and clopidogrel. And when you putting a catheter, is very painful, and it causes anxiety. It increases the heart rate, right? Causes anxiety and causes increased level of adrenaline and noradrenaline, which all are harmful, which will act to increase the myocardial ischemia. So don't put catheters. I mean, if the patient is cardiogenic shock, if you are giving IV furosemide, patient intubated, you might have to put a catheter, but not as soon as possible. Sometimes when the patient comes to the hospital, as before even you give aspirin, some people put a catheter, right? That is, catheter is not required. Please let your colleagues know in the peripheral hospital specifically, right? No catheter. And the oxygen, we used to, when we were medical students, it was taught all the patients MI should be given oxygen. Now they have done a trial and found out giving oxygen can be harmful. I don't know how it can be harmful, but trial says it's harmful. Maybe when you put a mask on a patient, it may be increasing anxiety, right? And some patients may have COPD or lung conditions, which you should not give oxygen, right? So only if saturation is less than 90%, now they suggest to give oxygen. Otherwise, don't give oxygen. And if you are sending the patient for primary PCI, try to put the cannula in the left side, because we have to use the right arm for radial artery access, because we do most of the interventions through the right radial artery. And other thing is, if you are transferring from a peripheral hospital, please send the patient's relatives or somebody, right? Because when the patient comes here, they will say, I have to ask my children, I have to ask my husband, I have to ask my wife, right? Then we can't do anything. I mean, it's better to thrombolize there than sending the patient to the primary PCI center and then waiting for the family to come, or again thrombolizing here, right? So it's not very difficult. I mean, you are sending the patient, ambulance is coming, so whoever who is available, you have to push in the ambulance and send them also to the primary PCI center, right? So those are few practical things, right? These are not, actually these are from the guidelines. We have already discussed those things. Right, oxygen is indicated in with hypoxemia, saturation less than 90%. Routine oxygen is not recommended. It can be harmful, right? You can give IV opioids for the pain. You can give benzodiazepines if the patient is agitated. So now this guidelines is from 2017, right? So if you look at it closely, primary PCI of the infarct-related artery is indicated. So that is what we do. After primary PCI, if the patient has ongoing angina, you might have to look at do another angiogram and look at whether there is a stent thrombosis. So stenting is recommended for primary PCI or balloon angioplasty. And earlier people said all the patients coming with primary acute STEMI should have clot aspiration. Now say routine clot aspiration should not be done. So new is not here. So you don't do routine clot aspirations now. Clot aspiration only for patients who has a very high clot levels. And stenting with drug-eluting stents is recommended, and radial access is recommended over femoral access by an experienced radial operator versus radial. We always prefer radial access because there are less complications. Again, first medical contact to ECG 10 minutes, maximum expected delay for STEMI to primary PCI less than 120 minutes. Right. So the times. So here, time delay from start of fibrinolysis to evaluation of efficacy. Now, when you give thrombolytic therapy, sometimes it will open up the infarct-related artery, so the ECG changes will come down, the ST elevations will come down by at least 50%. So you have to do a repeat ECG in 60 minutes after the fibrinolytic bolus to see whether the fibrinolysis was successful. If it is not successful, you have to send the patient for rescue PCI if the facility is available, right? Okay. This says we have to give prasugrel or ticagrel or clopidogrel before PCI and maintain over 12 months. Now these diseases also have been changed. Now they say you can only give aspirin loading dose, and you have to do the coronary angiogram. After the coronary angiogram, if you are going to do PCI, you can give loading dose of P2Y12 inhibitor. That's because there are some patients, when you do the coronary angiogram, you see the anatomy is not suitable for a PCI. You can't cross the lesion, right? Those patients will have to undergo primary CABG. So you immediately shift the patient to the operating theater, do a CABG, right? But it usually almost never happens in our country. So I don't think there is that kind of issue here. So you can give clopidogrel before, right? Aspirin as recommended, and glycoprotein 2B3 inhibitors usually are used only in the cath lab. Sometimes when you open up the infarct-related artery, you put a stent, and then there is no flow. You have opened up the artery, but there is no flow. So that is a very dreaded complication during primary PCI procedures, right? So patient will have more chest pain. Patient will become hemodynamically unstable. You inject dye, the artery is not perfusing. There is no flow in the artery. No, it's called a no reflow phenomenon. That has happened because all the clots and all the fat from the plaque has now gone and occluded the microcirculation. There's no very successful treatments for no reflow. So those instances sometimes we use GP2B3A inhibitors when there's heavy clot burden, like abciximab, eptifibatide. Right. So these are the doses: aspirin 150 to 300, clopidogrel 600 followed by 75. Prasugrel we don't use much around here. Ticagrelor loading dose is 180. Only things you have to remember is it has a short half-life. Maintenance dose is 90 mg twice a day, not one dose like clopidogrel. Abciximab, eptifibatide you won't be using. Right. So this patient, after the MI, he will go to the CCU. So they say at least for 24 hours, patient should be in a monitored bed, HDU, CCU setting. That's because VT and VF, arrhythmic events are very common even after successful revascularization. They can get VT and VF because the myocardium is damaged, it's very excitable. They can get VT and VF, right? You may need to give amidrone or shock. And other thing is you have to differentiate between VT and accelerated idioventricular rhythm. It will look like a VT, but the rate is less. Patient is hemodynamically stable. That is the difference between accelerated idioventricular rhythm and VT. So you have to give beta blockers early. We like to give beta blockers early, right? Now there were some controversy regarding giving beta blockers to patients with heart failure, but even acute heart failure. But if the patient's blood pressure is stable, if the patient is not on inotropes, we usually give beta blockers, right? So beta blockers can help. They have to be in CCU because there is other complications, mechanical complications of MI, such as there can be papillary muscle rupture or papillary muscle dysfunction causing acute MR. They can go into heart failure very suddenly. And there can be ischemic VSDs, patient can go into heart failure suddenly. Tamponade due to free wall rupture. Of course, if it happens, usually patient will die. They can develop cardiac shock and pulmonary edema, and other complications, stent thrombosis, because these patients, when we give antiplatelet drugs, there's no time for the antiplatelet drugs to act before we do the PCI. Now, for a routine PCI, we give the loading doses of aspirin propofol day before the procedure. So they will have very good levels of antiplatelets in their system. Now these patients, as soon as we come, you give the antiplatelets and then we directly take to the cath lab. So antiplatelet drugs still in the stomach. So there is a risk of stent thrombosis risk is higher in these patients, right? So one option is to give a fast acting antiplatelet like ticagrelor instead of clopidogrel, because ticagrelor has a better bioavailability and it will be absorbed soon. It will be so we sometimes use ticagrelor in acute, like to use ticagrelor in these patients. Right. So about stent thrombosis. So other thing is, if the patient is vomited after antiplatelet doses, you have to give it again. So that is one thing we ask when the patient is taken to the cath lab, whether the patient vomited after taking the medications, because they are anxious, their gastric emptying is also reduced. So we usually give some metoclopramide or ondansetron to aid gastric emptying. If they have vomited, we will give another dose of antiplatelets. Right. So in the ward, this is for the house officers mainly. You have to monitor the blood pressure and the heart rate. Basic things, very basic things. Patient who had MI will stay in the CCU for 1 day if beds are available. But if we don't have beds, we put in other monitored bed, right? Or sometimes we sometimes send them to the normal medical wards, right? So strategy behind this is now patients staying in a medical any bed, right, with a blocked artery, and you have to compare patients staying in any bed with the unblocked artery. So we say unblocked artery is better. So sometimes even if there is no monitored bed, we unblock the artery and send them to the normal medical wards depending on the available facilities. And you have to adhere to good glycemic control targets. Now, if the random blood sugar is more than 200, there is evidence to give insulin infusions, insulin as an infusion, right? And again, you have to mobilize the patient early also. And they mean don't know that was right? Patient first day do the PCI today. Tomorrow patient will be on the chair. Next day we send them home, right? So 2 days if you do primary PCI. If it is thrombolysis, we send them after about 5 days. If the successful primary PCI, we send them in 2 days. And patient, you have to let them eat also. No need to be starving. Some patients come to the clinic, 2 weeks they only had fluids, right? So no need to starve the patients. But again, That also depends now. If the patient has cardiogenic shock, blood pressure is to the lower side on inotropes, then they should not take very heavy meals. Those patients cannot tolerate heavy meals. Patients with cardiogenic shock and on inotropes, right? Uncomplicated patients with MIs can have anything to eat, but what I usually tell them, you can eat anything you want, but lesser amounts. So should not take a very big meal, right? So you had to auscultate for new murmurs to identify acquired VSG and acquired MR. If the patient has sweating, cold, clammy extremities, and patient says feeling unwell, move back to the monitored bed. You have to do echo before discharge, and you have to educate the patients now. MI is a good opportunity for you to educate patients on their lifestyle, right? Because before the patient gets MI, if you say not to smoke, they will not listen, right? Before MI, they will say don't take food rich in fats and sugar. They will say අපි හොඳට කාලා මැරලා යනවා කියලා. එහෙමනේ කියන්නේ. ඉන්න කාලේ හොඳට කාලා බිලා ඉන්නවා. But when you get MI, everybody wants to know what to eat, when to have a bath, everything. They will come and ask those things. So it's a very good opportunity for you to educate the patients on lifestyle modification, right? Right. I'll come to about the patient education because that is a very important part. So there is a few words about MINOCA. MINOCA is myocardial infarction with normal coronary arteries or non-obstructive coronary arteries. So patient comes, exactly everything is troponin is positive, chest pain is there, EC changes are there. You do a coronary angiogram, it shows there is no obstruction in the coronary artery. There can be less than 50% obstruction, which is or they are completely normal sometimes. So then you have to consider alternative diagnosis, including myocarditis, pericarditis, pulmonary embolism, some forms of cardiomyopathy, coronary artery dissection, thrombotic things like factor V laden and those antiphospholipid syndrome, those things. So we refer them to the hematologist. Coronary artery spasm, type 2 MI, stress induced, right? Type 2 MI is when there's a supply-demand mismatch, like patient has anemia, tachycardia, that kind of patients. So after surgery, right, they can get positive troponins, but coronary arteries are normal, right? I think we don't have to discuss much about fibrinolytic therapies. Right. So here I would like to highlight in patients less than 75 years, they say 30 milligram bolus enoxaparin followed by this thing, right? More than 75 years, no IV bolus, right? So they always think about 75 is a cutoff. Like if the patient always, when you get a MI patient, think if they are 75 or not, and then that will alter your treatments, right? Sometimes even, some patients are there who are not 75, but they look older than 75. They are very frail, right? They have very wrinkled skin, and they are very emaciated, right? Little bit of CKD, right? Cannot walk, right? That kind of patient also you have to consider giving lesser doses of low molecular weight heparins and probably other medications as well, because they have high risk of getting bleeding complications. Right, I think you know all these things. I don't have to mention everything. So what are the contraindications for fibrinolytic therapy? One thing you have to exclude is aortic dissection, because if in aortic dissection, if you give thrombolytic therapy, aortic dissection will be worsen and patient will die. So especially aortic dissection is common when the escalations are in inferior leads. So when the patient comes with the inferior STEMI, you have to be a little bit careful. Ask about the history. Whether patient says pain is radiating between shoulder blades, and check the blood pressure in both arms, especially in the case of inferior STEMI, because then you might have a clue to aortic dissection. Right. So now we have to send the patient home, right? So this is the lipid profile of the patient. LDL is 106 after acute coronary syndrome, right? It's normal here. This is normal, right? Some reports will say optimal, right? Some reports will say optimal. Some reports will even say low, not 106. If it is like 65, they will say low. When the patients are agitated, right? Atorvastatin adu karanna ඕනද? Right? So we have seen some doctors even reducing the dose of statins after MI, after acute coronary syndrome. So you should not do that, because now this is not in this 2017 guideline also. So you have to give statins to achieve LDL cholesterol goal of 55. That is the target. 55 is the target. LDL 55. So I think, and there is another you can, if the baseline LDL level is low, you have to achieve at least 50% reduction. Low, whichever is lower. Like when the patient had MI, if the patient's LDL was 80, that means you have to bring it down to 40, right? Otherwise, patients who have higher levels, you can say patients who have LDL cholesterol more than 110, you should bring them down to 55. Less than 110 LDL patients should go down to half of their initial value, right? Now these guidelines also actually might change. Now it was 70 in 2017 guidelines. Now it's 55. In the future it will further drop, because India is now taking 45, I think 45 or 40 LDL target in very high risk patients, like patients who already have vascular events like coronary artery disease, right? Okay. So that is the secondary prevention statins, right? You have to give beta blockers. Consider beta blockers for all the patients, right? And then you have to give ACE inhibitors, right? Usually all the patients now, patients who have had a MI will get aspirin, P2Y12 inhibitor like clopidogrel, high dose statin, atorvastatin 40, or you can go up to 80, rosuvastatin 20, you can go up to 40, and 3 drugs there, and then beta blocker, and then ACE inhibitor, right? 5 drugs, right? At least these 5 drugs should be started before discharge. Aspirin, clopidogrel, atorvastatin, enalapril or ramipril with beta blocker, right? And now they say recent lipid, now there's talk in the developed countries whether you should start ezetimibe or PCSK9 inhibitors also at the time of the MI, without waiting to see the effects of the statins, right? So they are treating with all they have for the LDL cholesterol, right? You start high dose statins. So you know, because you know, by giving high dose statin, atorvastatin 80 or rosuvastatin 40, your LDL cholesterol reduction is would be 60% max. So LDL can be reduced by 60%. That is the maximum you can go with as atorvastatin, rosuvastatin. So if after 60% reduction the value is more than 55, that means you should give more. So they now talk about whether we should give other cholesterol lowering drugs also at the beginning, not waiting for the LDL effects to see. I mean, it's not they are not in the guidelines. I mean, I'm saying this because now LDL reduction is very important. So you have to achieve your targets. If you are not achieving 55, don't hesitate to increase the atorvastatin dose to 80. So because we have 20 milligram tablets, patients don't like to take 4 tablets. That is another problem, right? So one thing you can do is, if they can afford, you can give rosuvastatin. It's the same dose, but it's twice as effective. So you can, now patient is on 40 milligrams atorvastatin. They don't like to take 80 milligrams of atorvastatin. So instead you give 40 milligrams of rosuvastatin. So they are very worried about the amount of milligrams. So that's why you can do that. That's one thing you can do. And you give spironolactone or eplerenone if the EF is less than 40%. Otherwise, no need. Right, discharge medications. Explain the indication for each to the patient and to the family. Now, what happens is when somebody takes, now these are practical points. When somebody comes to take the patient home, right? Now, the nurse will explain to them, right? But the patient is on the bed, right? Patient is not there usually, and the person who takes the patient home leaves the patient there and goes. Now, if a patient has 5 sons, someone will come to pick the patient from the hospital, but that information will not pass to the family members patient is living in. That is one of the major problems. මුකුත් කිව්වේ නැහැ කියලා කියන ඇවිල්ලා hospital එකේ ගිහුවා injection ගැව්වා මොනවත් කිව්වේ නැහැ. කිසි දෙයක් විස්තරයක් කිව්වේ නැහැ. That's most of the time that is not true. Anyone will say something at least, right? So they will come and say මොනවත් test දුන්නේ නැහැ. ECG එකක්වත් දුන්නේ නැහැ. බැලුවා මල්ලේ තියෙන ඇතුලේ හරි. So you have to explain the indication for medication to the patient and to the family, right? And you have to tell them they are for life. මේ බේත් කොච්චර කල් ගන්න ඕනද? සදාකාලිකව ගන්න, right? So patients don't like to listen to that. Patient එහෙම අහන්න කැමති නැහැ. හැමදාම ගන්න ඕන කියන කැමති නැහැ. When they go home, the neighbors will come and say, oh බොන්න හොඳ නැහැ. වකුගඩු නරක් වෙනවා, kidneys වලට හොඳ නැහැ, right? Even some patients waiting in the clinic outside sitting, they also say to other people, oh, that cholesterol peta digatama ganna honda naha කියලා පඬිතුයෝ ඉන්න එහෙම අවවාද දෙන්න, right? So you have to be explained to them. If a doctor explains, that has some weight, right? So explain possible adverse effects. That is also important. නැත්තම් බේත් ඔක්කොම නවත්තනවා දැන්. මොකක් හරි adverse effect එකක් ආවොත් they will stop all the medication and go to මොනවාරි කසාය හරි මොනවාරි බොන්න යනවා ඊළඟට, right? කසාය වල adverse effects නැහැ නේ කොළ තම්බලානේ, right? So you have to tell them the adverse effects. Aspirin can cause gastritis. So if you have gastritis, come, we'll do something about that, right? Statins can sometimes cause muscle pains. You can do something, right? Beta blockers can cause wheezing, or beta blockers can cause erectile dysfunction in men. And sometimes some people can't tolerate beta blockers, right? They don't have a specific thing, but they can't take beta blockers. When they take them, they feel very fatigued, feeling unwell, very can't take. So those adverse effects you have to explain. And cough with ACE inhibitors. Now in Anuradhapura, I have noticed is most of the textbook side effects will be seen in these patients. Compared to other areas, our people have all the textbook, they get all the side effects. If you can't give inhalable, they will get cough, definitely, right? You can't give statins, they will get myalgia, right? Exactly like in a Western country, you will get all the textbook side effects, right? So you have to explain the side effects, otherwise it's difficult, right? Explain the risk factors and their modification, right? You have to give the targets. සීනි පාලනය කරගන්න ඕනේ. එහෙම කිව්වට that is a very vague, right? එහෙම කියලා වැඩක් නැහැ. So you have to say, you have to control the blood sugar. Your fasting blood sugar should be less than 110. Your HbA1c, there is a test called HbA1c, that has to be less than 7, right? නැත්තම් බෙහෙත් බොනවා කියලා තමයි කියන්නේ. බෙහෙත් බිව්වට control නැහැ, right? And you should have a cardiac rehabilitation program. Now our cardiac rehabilitation program is started. We had to stop because of the COVID. We had to start it again. So cardiac rehab can help the patients after acute MIs, acute coronary events, right? So you tell them HbA1c target, LDL target, blood pressure target, right? And you have to tell them when to drive, work, and when to resume sexual activity, because our people are very reluctant to work after MI. හැමදාම medical ඉල්ලන් එනවා, right? මාස 3 6 එමොන්නේ, right? You can drive a light vehicle after 1 week. That is after normal primary successful revascularization. Work in office-like setting after 1 week, normal work, right? Sexual activity, of course, debatable. Patients who had a simple MI and revascularized, they can have as early as 1 to 2 weeks, right? And there are certain instructions to give. Now they say roughly sexual activity you need the energy required to fight a climb about 2 flights of stairs. So if you can climb 2 flights of stairs, then you are okay to have normal sexual activity. So that is what you have to tell them, because people are a bit reluctant to ask, right? And other things, beta blockers can cause erectile dysfunction. That also you have to ask the patients, right? One clue is patient will come to the clinic and ask for vitamins, right? If they ask for vitamins, that might be an indication they have erectile dysfunction. So you have to ask for whether they have erectile dysfunction, right? So our clinics are also not very conducive to discussing these problems. Right? So after MI, they have anxiety and depression. Also, people need sometimes depression medications, and they have very frequent health-seeking behaviors. Right? And they have probably loss of income. People treat them as invalids, right? And the cost of medication now, if you have MI and heart failure, cost is, if you take Indian drugs even, it will be about 30,000. If you have diabetes, 40,000 per month, right? So your usual average income is people usually about 50,000, 30 to 50,000, some jobs, right? So you can't spend all that for the medications. Now people used to come, patients who are followed in the private sector, they will come and say, they'll ask a letter to come to the hospital. That happened about 3-4 months ago. Now they are coming back to the private sector because the drugs are not even available in the hospital. So now there is no difference, right? So you see people take medicines for 1 week, next week they are not taking medicines, right? Really pathetic. And on the other hand, I think it's important for them to bear the at least partial cost of medication. Now, all the medication, if you provide from the hospital, some people think now they don't understand the value of it, right? So, like if the patient is a smoker, there are patients who smoke 10 cigarettes a day, but they are reluctant to spend that money to buy a medicine, right? So, you can, to tell them that the importance of these medicines, what I do is, instead of giving atorvastatin, I prescribe rosuvastatin, right? So smokers, so they can stop the smoking, and from the money they save, they can buy the medicine. So it's something for them to do, right? And there is side effects and compliances issue, right? So after MI, usually males tend to do better compared to females. That's because wives usually look after their husbands well. Now, the food, if you say not to give fat or something, even after 2 years, he will be getting too many kiring situation here. So, I think okay, so that's of course everything I have to say. In summary, you have to know that acute coronary syndromes are very, very common, right? So so sometimes acute coronary syndrome may present over the phone to you, right? Doctors right? So always ask them to do a ECG, always ask them to do a troponin. Don't say, let them take something for gastritis. If the patient says it's gastritis, you have to be very careful, because if the patient says it's gastritis, usually it's likely to be MI. Right? If the patient thinks it's MI, it's some other musculoskeletal pain, right? That is the usual thing, because there are two kinds of patients. Some are very very anxious. They seek. They have very low threshold for health-seeking behaviors. They come to the doctors even at a minor thing. So those patients, when you come, they are usually not MIs, right? Remember, we are at high risk, right? Better to be thorough. And what patients want to hear is, බය වෙන්න දෙයක් නැහැ නේද? ඔක තමයි අහන්නේ. දැන් ඔය පැය ගානක් කරන් ඔක්කොම පැහැදිලි කරලා මේ heart එක හොඳටම damage වෙලා තියෙන කිව්වට පස්සේ එහෙනම් ડોක්ටර් බය වෙන්න දෙයක් නැහැ නේද කියලා අහනවා. බය වෙන්න දෙයක් තියෙනවා. ඒක නිසා තමයි මෙච්චර වෙලා අරන් කිව්වේ කියලා කියන්න ඕනේ, right? So reassurance is one of the things doctors should do, but don't try to reassure patients without knowing everything. You have to have a troponin, echo, or ECG, do everything, and then you reassure, right? Don't say බය වෙන්න දෙයක් නැහැ කියලා කිව්වම ඊට පස්සේ ඕක තමයි කියන්නේ හැමතැනම. බය වෙන්න දෙයක් නැහැ කිව්වා කියලා, right? Right. So any doctor should know how to identify acute coronary syndromes on ECG. Right? Management is usually straightforward. Guidelines are there, but some things in the guidelines we can't do in our city, right? Okay, so that's the end of my presentation.